The title of today's lecture is Clinical Linguistics and Natural Language Processing. And what we're going to be talking about very simply, very roughly described are the following topics. We're going to be discussing language and healthy aging. So what kind of features characterize speech and language in general when you age, when you become an older individual. We're going to be comparing that to how language is particular in individuals that have pathology, so disease, so language and pathological aging. We're going to move on to discussing specifically Alzheimer's disease and the kind of effect that it has on language. And then finally, we're going to be talking about a couple of studies that have tried to use natural language processing to detect Alzheimer's. And the main upshot is that you can use language to detect the symptoms that are associated with Alzheimer's disease. And this is a very cheap way of detecting disease because other methodologies that we have are much more expensive or they take much longer. So as linguists, we are in a very unique position to be doing something about this. So to be furthering the research in Alzheimer's diagnosis, which is really quite something if you think about it. All right, so what it is that we are talking about when we're talking about clinical linguistics. So clinical linguistics is a subdiscipline of applied linguistics. So all those kinds of disciplines that take formal linguistics or any kind of linguistic knowledge and try to apply those to the real world to have some kind of real world impact. Clinical linguistics try to have a real world impact by applying formal linguistic knowledge to pathologies, to diseases. So with clinical linguistics, you can do a number of things. You can try to describe a pathology better by describing better the kind of symptoms that it has on language. You can try to devise ways of treating the language disfluencies that you might have with a specific disease, or in general, just describing what is going on better, just trying to understand why it is that you've got those specific language disfluencies. Today, we're going to be focusing specifically on Alzheimer's disease, and Alzheimer's disease is a pathology that affects older populations. Why are we so concerned about Alzheimer's and why are we so concerned about elderly individuals? Well, that is because the world is becoming older and older. So the number of people above a certain age is becoming higher and higher. So if we look at estimates from Eurostat, for example, the proportion of individuals that are over 75 years of age is going to be reaching 30% of the population in Europe in 2060. And if you compare to what we had in 2010, when it was just 16%, that is almost double what we had just 10 years ago. So the number of older people is going to become higher, which means that the number of people suffering from pathologies that are associated with old age is going to become higher. Specifically, people over 80 years of age are predicted to be 12% in 2060. And again, if we compare this to what we had in 2010, when people over the age of 80 were only 5%, again, that is quite a jump. Focusing on aging and cognition. So aging is associated with a kind of persistent cognitive decline that generally starts around the age of 65. So there's nothing you can do about that. It's just a normal fact of life that as you become older, as you age, your cognition is not going to be as sharp as it was when you were younger. And what we have to distinguish here is non-pathological aging from pathological aging. So non-pathological aging is essentially just healthy aging. So there is a cognitive decline, but this cognitive decline does not compromise the quality of life of an old person in daily living. Pathological aging, on the other hand, is a condition where you are an older individual and your quality of life is affected because your cognitive decline is so severe that it affects your day-to-day life. And it affects your day-to-day life in a way that is not normal if compared to healthy individual of your age. So how you define what is normal and what is not normal, of course, is always dependent on the kind of age matching behavior that you see according to research. Focusing on healthy aging and language. So what we're going to be doing for the next couple of slides is we're going to be looking at language in healthy individuals, healthy older individuals. And that is because, as I said, aging starts around the age of 65, and that comes with a number of symptoms that are just normal, but still they come with a degree of cognitive decline. So one thing that we notice when we age is that our voice changes. And that is perhaps one of the features that are most recognizable in aging. We all have a grandma or a grandpa, and we can see that their voice is very different from our own. Presbyphonia is a term that we use to characterize and describe the specific clinical characteristics that are associated with the aging voice. Terms that have been used to describe the voice of an older individual are things like their voice is more shaky, their voice is more breathy, squeaky, weak, and hoarse. So the voice feels less stable, it is more shaky, it is less loud than a younger individual, and it may feel like the person has a bit of a throat ache when they're speaking. Older people are also unable to sustain adequate volume in a noisy environment. And this again is related to this perception of the older voice being weaker than a person that is younger in age. So let's check this video to get an idea exactly how the older voice sounds like, if this works. If you don't hear the sound, please let me know. No sound? Let me see if I can do something about it. All right, I don't know how to fix this. So let's just assume that we saw the video and we realized that the person is speaking with a much weaker voice. And like I said, when you're thinking of how an older individual speaks, you think of a person that sounds like they've got issues with their throat. So if you've ever had a throat ache, that's sort of what that sounds like. It's a weaker voice, it's a shakier voice, and it's a breathier voice. And this is due to a number of factors. This is due to the fact that your lungs do not push out as much air as when you were younger, so the sound that you produce is weaker. This is due to the fact that the cartilage in the larynx calcifies, so the vocal cords have less tension, so produce less loud sounds. And this is just a normal fact of aging, but it is something that we have to consider when we're dealing with automatic language analysis, because if we are, for example, listening to an audio and we're trying to transcribe that audio, well, this specific acoustic features of the older voice are going to potentially make it harder to transcribe the data that we have in a correct manner. And this is something that we see very often in our own project, for example. So we talked about the acoustic feature of the aging voice. Let's look at other features that describe the language of older, healthy individuals that are not necessarily related to phonetics. One such feature that is very, very salient in the language of older individual is word retrieval, and specifically the fact that older people say very often that they have trouble remembering words that they're sure they know. So this phenomenon is called tip of the tongue disfluency, or tip of the tongue. And it's the phenomenon by which you're trying to say a word, you know for sure that you know this word, so you've been using this your whole life. For example, you're thinking of the word book or cat, so it's definitely something that you know, but when you're trying to use it in a sentence, suddenly you feel like you're not able to remember what that word is. So you struggle a lot. I'm sure you've experienced this yourself and you're not old. So just by thinking of this, you can tell that this is not a phenomenon that just affects older individuals. This is definitely something that we all experience, even younger people. But it's definitely something that becomes much more salient and much more frequent as you age. And I think it is particularly interesting that this is one of the cognitive functions that are sort of impaired as you age, because other related functions that relate to semantics are not as impaired. So for example, older individuals have no trouble understanding the meaning of a word. And that is very interesting if we compare it to the fact that they have trouble remembering what that word sounds like. What is interesting about tip of the tongue experiences is that the gap in your brain that you cannot fill with the word that you need is very active, in the sense that you generally sometimes remember pieces of the word that you need. So for example, if you want to say eccentric, you might end up saying, it's a word that starts with X or something like that. There's an E somewhere. So you do remember bits and pieces of the target word, but not the target word per se. And you might also end up saying a word that is related to the target word, but it's not the target word. And this wrong word has some parts of its phonetic contour in common with the target word. So for example, you want to say eccentric and you end up saying exotic because the two words start with a similar syllable. So what does this entail? So because older individuals have a harder time finding the words that they need, they end up producing more pauses and they end up producing more ambiguous references. So for example, my mom will often say, oh yeah, that thing over there. And she sort of expects everybody to understand, but of course we don't know what she necessarily means. And the reason she does this is that because she's thinking of a word, she cannot remember what the word is. And so she goes for, yeah, that thing over there. Or more frequent pauses because an older individual is trying to remember the word that he needs, but cannot remember what it is, or just producing a word that is similar in shape, phonetic shape to the target word, but is not the target word. Like, for example, eccentric and exotic. So we've talked about language effects, and it's also interesting to briefly look at non-linguistic effects, because some of these non-linguistic effects have an effect on language. In healthy aging, so in non-pathological agings, you do get a number of deficits with respect to younger ages, and these deficits are generally in episodic memory, attention, reasoning, and temporal and spatial perception. Episodic memory is particularly relevant, especially in the context of Alzheimer's. So we're going to be talking about it a bit more in detail. So episodic memory, first of all, is part of the long-term memory system. We've got the short-term memory that helps us remember the digits that people tell us over the phone. So for example, if I'm calling somebody and I tell them this is my number, short-term memory is about remembering those whatever number of digits for a short while so we can write them down. Episodic memory is not part of that system, it's part of the system that allows us to remember information in the longer term. And specifically, episodic memory is a cognitive system that enables someone to record, store, and retrieve information about personal experiencing and about the temporal and spatial context of those experiences. So episodic memory is involved if somebody asks us, what did you have for breakfast this morning? Or what did you have for breakfast 5 days ago? Or what did you do when you were 12 and you went to whatever place? So what is particularly interesting when we're talking about healthy aging and memory is that different types of memory systems are differently affected. Episodic memory is affected. Short-term memory, so remembering digits that somebody just said to us, is not affected. That seems to be quite normal, seems to be quite on par with the way that younger individuals deal with. Semantic memory, which is about word knowledge, and it's also about the meaning of words, is also not affected. So an older individual will remember that the earth is round or whatever kind of general knowledge fact. But like I said, episodic memory is affected. So an older individual will struggle to remember something that happened 2 days ago, or they will not remember this event with as many details as a younger person could recall this event with. Do you have any questions so far? No? All right. So we've looked at healthy aging, so non-pathological aging, and we focused on the effects that non-pathological aging has on language. And we looked at the effects that it has on voice and the fact that individuals that are older have trouble remembering some memories. And now we're going to be looking at pathological aging, and we're going to be focusing on dementia. So dementia is a very popular word nowadays, but it is often used incorrectly in the sense that many people assume that dementia is essentially a synonym for Alzheimer's disease, but the two terms refer to different things. So dementia is not a specific disease, but it's rather an umbrella term, it's a general term that describes an impaired ability to remember, think, or make decisions. And this impaired ability to do all of these things has an effect on everyday life. Whereas Alzheimer's disease is a specific kind of disease. It has its own causes, its own separate causes, and its own separate symptoms. Because dementia is a general term that describes an impaired ability to do a number of cognitive functions, there are many different types of dementia. There is Alzheimer's disease, which is the most frequent kind of dementia, but we also have vascular dementia, Lewy body dementia, frontotemporal dementia, and other types of dementia as well. And this image does a very good job at showing you that these different types of dementias have different causes and different symptoms. So for example, Alzheimer's disease, we'll see that more in detail, is caused by buildup of proteins in brain structure, but vascular dementia is caused by reduced blood supply to the brain. And what we're going to be focusing on again is Alzheimer's disease. Why do we care about Alzheimer's disease so much? And why do we not care so much about vascular dementia, for example? Well, that is because Alzheimer's disease is much, much, much more frequent than other types of dementia. So dementia in general, as a condition, so as an umbrella term, is an umbrella term that can be associated with around 55 million people worldwide, which is a huge, it's an incredibly high number. And it's estimated that there are around 10 million more cases per year. So it's really a condition that really does affect a huge number of individuals. And to contextualize that by using smaller numbers, it's estimated that 1 in 14 people over the age of 60 suffers from dementia, and that proportion rises up to 1 in 6 people if you're talking about individuals over the age of 80. When I said that Alzheimer's disease is the most frequent type of dementia, I meant that out of all the cases of dementia that we have, 60 to 80% of those cases are cases of Alzheimer's disease. If you are a woman, sadly for you, you're more likely, you're almost twice as likely, or even 3 times as likely than a man to be suffering from dementia in the future. And we don't know why that is. The good news for women is that women tend to live longer than men once they're given a diagnosis of dementia. What causes Alzheimer's disease? The short answer is that we don't know for sure. So we have some ideas, we have some suppositions, but it's clear that we don't really have the full picture of what is going on when somebody has Alzheimer's disease. So what we know so far, what we think so far, is that Alzheimer's disease is caused, or thought to be caused anyway, by an abnormal buildup of specific types of proteins in the brain. And we don't know what causes this, but we're fairly sure that these types of proteins, there are 2 types of proteins, amyloid and tau, are related, or are sort of relevant to understand what is going on in the brain of a person with Alzheimer's disease. And these proteins causes plaques or tangles in brain cells that reduce the volume of the brain overall, because they cause some parts of the brain to die, and they also cause a decrease in chemical messengers that are involved in sending signals between brain cells. So this is a very famous picture of that is comparing the brain of a healthy individual to the brain of a person that has severe Alzheimer's disease. And you can see that there is a very noticeable difference in volume between the healthy brain and the Alzheimer's brain. And this reduction in volume is very clear if you look at the ventricles. So the empty spaces in between the folds of the brain, you see that in the case of a person that has Alzheimer's disease, those empty spaces are much, much larger than what we see in the healthy brain on the left. When I said that we don't really know for sure what is causing Alzheimer's disease, I meant that some individuals that experience these buildups of proteins in the brain, so they have these plaques of amyloid proteins in the brain, do not show the symptoms of cognitive decline that is associated with dementia, with Alzheimer's disease. So we have a very strong suspicion that proteins, plaques, are what is relevant to understand Alzheimer's, but at the same time, we have individuals that have those plaques in their brain and they do not experience the symptoms of Alzheimer's disease. So there's clearly something additional other than these plaques of amyloid and tau proteins that has an effect on the brain of individuals that experience cognitive decline. We just don't fully understand what that is yet. What are the symptoms of Alzheimer's disease? So it's not just about being forgetful, and it's not just about forgetting some words. It's much, much worse, sadly. An individual with Alzheimer's disease is going to experience confusion and disorientation. So they're often going to get lost. They're going to forget what they were doing. They're going to forget what time of the day it is. They're going to be experiencing delusions and paranoia. One very key thing for us is that they're going to be experiencing issues with their language production. They're going to be having a harder time sleeping decently and falling asleep. Alzheimer's is also associated with mood swings, depression, anxiety, aggressiveness. In the later stages, individuals with Alzheimer's might have difficulty eating on their own and also swallowing, which is going to be causing weight loss, sometimes quite extreme. In the later stages, they're going to be having difficulty moving on their own, so moving without assistance. There's going to be a gradual loss of speech, so inability to produce words that make sense. And in the later stages, we're going to be having significant problems, not just with long-term memory, but with short-term memory as well. So it is quite a dark picture. Alzheimer's is a long-term disease. It comes in stages. Many people divide the stages of Alzheimer's into these 4 stages that I've depicted here. You also have more, more stages according to different authors, but I think this is a decent way of understanding the way in which Alzheimer's progresses. So first of all, you've got a preclinical stage. This is a stage where you have the causes, you have the symptoms in your brain of Alzheimer's disease, in the sense that your brain is starting to accumulate these amyloid plaques, but you don't have any of the cognitive symptoms. Then you move on to mild cognitive impairment, which is a stage where you start to experience cognitive issues, and then these cognitive issues become more and more severe, moving on to mild dementia, and then finally to moderate to severe dementia. So looking at 3 of these stages more specifically, again, preclinical Alzheimer's disease is when you do have plaques in your brain, or your brain is starting to look in a way that it should not be looking, but you still do not have any kind of cognitive symptom. So you might have Alzheimer's disease, clinically speaking, but you don't realize that you have it because there's nothing wrong with the way that you talk. There's nothing wrong with the way that you reason yet. Mild cognitive impairment is where the bad things start. And this is the stage where you experience word retrieval difficulties. So what we saw for individuals that are healthy and older, but more so that healthy individuals. You also start forgetting recent conversation, and this is an example of the episodic memory that we were talking about earlier. You struggle with completing familiar tasks, and you might get lost in places that you definitely have been in before. And then Alzheimer's dementia, and this is comprising of mild dementia, moderate dementia, and severe dementia, is when you've got severe cognitive deficits, and these deficits are so bad that they interfere with social functioning, and sadly generally require the assistance of somebody that helps you with day-to-day activity. I said that Alzheimer's disease is a long progression disease, and sometimes people don't fully understand how long of a time scale that is. So the full progression from preclinical Alzheimer's to your death can take up to 20 years. The preclinical stage is estimated to last around 10 years. The mild cognitive impairment stage lasts around 4 years, mild dementia 3 years, and then moderate to severe dementia around 3 years. And then after 3 years, individuals generally die. So you might be wondering, what is the cure for Alzheimer's disease? And the bad news here is that there is currently no treatment, no cure for Alzheimer's disease. So we do have drugs that reduce or control the symptoms, but they're not disease-fighting agents in the sense that they're not doing anything to stop the condition or revert the condition. What we have at the moment are drugs that control the cognitive symptoms, so make it possible for you to forget less, things and just conduct a more normal daily life for longer. But they're not going to doing anything. They're not going to be doing anything to stop the disease itself. There is one drug. There is one drug that got a lot of attention recently, and this agent is called aducanumab. And this currently is the only existing disease-modifying drug that is used to treat Alzheimer's disease. But the point is that the evidence that this is actually doing anything is very underwhelming. And it is so underwhelming that this drug is approved in the US, but it's not approved by the European Medicine Agency. The reason why the European Medicines Agency did not approve this drug, you can read them here in this report. So the European Medicine Agency noted that although Aduhelm, this is the name of the drug itself that contains this agent, aducanumab. Although Aduhelm reduces amyloid beta in the brain, the link between this effect and clinical improvement had not been established. Results from the main studies were conflicting and did not show overall that Aduhelm was effective at treating adults with early-stage Alzheimer's disease. In addition, the studies did not show that the medicine was sufficiently safe, as images from brain scans of some patients showed abnormalities suggestive of swelling and bleeding, which could potentially cause harm. Furthermore, it is not clear that the abnormalities can be properly monitored and managed in clinical practice. So in short, this drug seems to be reducing the plaques in the brain that are caused by this buildup of proteins, but that does not seem to be reducing the symptoms of cognitive decline that come with Alzheimer's disease. Not only that, this drug also seemed to be causing some harm. So you've got swelling and you've got bleeding in the brain, which is really not a good sign. So there is no treatment for this awful disease that is Alzheimer's disease. But how do we diagnose Alzheimer's disease? We've got a series of standard procedures that are used in memory clinics throughout the world, and these procedures include neurocognitive testing. So individuals go to memory clinics and they are asked to undergo a series of tests that we're going to be seeing more in detail later. You can also diagnose Alzheimer's disease through different types of brain imaging procedures, so PET, MRI, less frequently EEG. And another thing that you can do is you sample cerebrospinal fluid by means of a lumbar puncture. So generally these three things are done together. You don't just do neurocognitive testing, you do neurocognitive testing, an MRI or a PET scan, and then lumbar puncture. Zooming in on neurocognitive testing, there is a very, very popular test that is administered pretty much throughout Europe, and this test is called Mini Mental State Examination. It is a pretty old test. It was designed in 1975, and it is very popular and still used nowadays because it is very simple to use, very simple to administer. And this test consists of a series of questions that are asked to the person that is suspected dementia patient, to see what kind of responses they give. And if the responses they give are incorrect or abnormal, then you suspect that there might be something going on. The questions are actually very, very basic. So here are some of the questions that are part of this test. And you can see it's very basic stuff. So what is the date today? What is the season? Which floor are we in? Where are we? And then the practitioner is going to be saying three objects: apple, table, and penny. And we're asking the individual that is coming to the clinic to repeat these three objects. The clinician is going to say a word, and then you ask the individual to spell it backwards. the clinician is going to say, remember the things that I mentioned a while ago, apple, table, and penny, which objects were they? Can you repeat them? So this is a more of a, I wouldn't say long-term memory, but it's a delayed memory. You show the patient your watch, and then you ask them to name what object that is, and they're supposed to be saying that is a watch. You show them a drawing, and you ask them to copy this drawing on a piece of paper that you provide them, and then you tell them, take this piece of paper, fold it, and then place it in your lap. So it's very basic stuff. But if you are a person that struggles with mild dementia, or even mild cognitive impairment, you're going to be having difficulties performing some or all of these. Another test that is often administered in clinics are fluency tests, and you've got different types of fluency tests. So the kind of test that we are administering here in Reykjavik, for example, is called a 10-word recall test. And essentially what you're doing is you're giving patients a list of words, you're telling them 10 words, and then you're asking patients to try to recall as many of the 10 words that you've given them as they can. Another test is called phonemic fluency test, and this is a test where we ask individuals to try to name as many words as they can think of that start with the letter B, D, whatever letter you want. The clock drawing test is also a very, very popular test. What you're doing as a clinician is you ask your patient to draw a clock, and then you ask the patient to draw the clock such that it shows a specific time, like 4:10 or 4:40. And again, this seems like a very, very basic task that you expect people not to make any mistakes with. But if you take a look at this image, you can see that the difference between the drawing of a normal individual and the drawing of an individual with a severe Alzheimer's disease is really quite striking. So a normal individual, of course, the drawing does not look perfect, but it is hand-drawn. Everything is in place. The numbers are where they're supposed to be standing. And then we compare the severe Alzheimer's disease drawing, and we see that the numbers are definitely not where they're supposed to be. And this is even more evident in this case, where the number are not even following the circle of the clock. What is the issues with the procedures that we have at the moment, and why did people think to be looking at language to diagnose Alzheimer's disease? The procedures that we have at the moment are very effective, but they are very costly and very time-consuming. So, for example, MRIs are extremely, extremely costly, not just for the patient, but also for the clinic. And they're just costly procedures to administer because the machines cost a lot of money. You need a specific trained individual that can operate the MRI machine, and it takes a long time to go through an MRI test. Procedures like EEG is much, much cheaper, but it's still very time consuming to do, because if you've ever done EEG, you need to go there. They need to place a cap on you. Each cap has a specific, as a set of electrodes that need to be placed in. There is gel application. The whole thing can take 1 hour for the patient and then 2 hours for the person that has to set up everything and then clean everything afterwards. Neurocognitive tests. We saw the clock drawing test. We saw the mini mental state examination. Those are definitely not expensive to administer, but still, you cannot just take them at home. You need to go to a specific memory clinic where an individual that knows what they're doing is administering that test to you. Also, because if you think of the clock drawing test, there are millions of different ways in which you can determine the degree of severity of cognitive decline. So do you look at where the numbers are? Do you pay more attention to whether the individual managed to tell the time correctly, so to draw the time correctly? So there are many different ways in which you can interpret those drawings, and it's important that it's a person with training that determines how to interpret those tests, the results of those tests. So these are the intrinsic problems with these kinds of procedures. Another issue is that clinics where you can take these tests or the hospital where you go for your MRI are often overbooked. So here in Iceland, we have a memory clinic, and Iceland is not a gigantic country. We are much less than 1 million, but still the standard waiting time to be admitted to a memory clinic here is 2 to 4 months, which is an enormous amount of time if you're suffering from memory issues, because those are severely debilitating and they affect your day-to-day life. So the fact that all the procedures that we have are costly, they're time consuming, and the fact that clinics and hospitals are overbooked results in delayed diagnosis. But also once you have your diagnosis and you know that you've got Alzheimer's disease, the fact that it takes so long to take a test is causing greater difficulties in actually monitoring the disease progression properly. Which is a terrible thing, because early detection is extremely important in general for any kind of disease, but also for Alzheimer's disease. And you might think, okay, why do we care about early detection if there is no cure for Alzheimer's disease? Why would you even want to know if you've got Alzheimer's disease if there's nothing you can do about that? Well, there are many reasons you should care. First of all, if you know that you've got Alzheimer's disease, as soon as possible, you've got time to plan for your future, and your carer, so the person that is going to be looking after you, also has time to psychologically adjust to the fact that they're going to have to take care of you or think of ways in which they can do that. If you know that you've got Alzheimer's disease, you can access treatment that can control your symptoms. So if you've got memory issues, you can take drugs that reduce those symptoms and you don't have to suffer through those memory issues. You can lead a normal life, more normal life at least, than if you were not aware of your diagnosis. Individuals that are treated earlier in general also live longer and show a 20% lower rate of institutionalization. And finally, there is no cure for Alzheimer's disease now, but there might be one in the future. And once there is a cure for Alzheimer's disease, it's going to be imperative to be able to diagnose this disease as early as possible. Because if you've got a drug stopping agent that can stop Alzheimer's disease but not revert it, well, it's really important to be able to start with the treatment as soon as possible. Right, so why are we talking about language, and why are we linguists in a particularly privileged position to be doing something about Alzheimer's diagnosis? Well, that is because language dysfunctions are one of the symptoms that are associated with Alzheimer's disease. And actually, it's been speculated that they're one of the earliest symptoms as well. Because if you remember what we talked about, when we talked about mild cognitive impairment, we said that one of the symptoms that is associated with mild cognitive impairment, which is the stage right after preclinical Alzheimer's disease, are word retrieval difficulties. So language dysfunctions appear to be one of the symptoms that are associated with early dementia, which means that we can use linguistic features and we can use language analysis to diagnose Alzheimer's disease, but also, in principle, to monitor the progression of the disease. So it's two very important things that we can do with language, which is what we specialize in, which is great. What are the advantages of looking at language as opposed to running an MRI or an EEG? The MRI and the EEG are always going to be more accurate, at least they're going to be more accurate at the moment, but language has a number of advantages. First of all, language data is cheap to collect. It comes for free. You can talk to somebody and they can give you language data for free. A second advantage is that collecting language data is a non-invasive procedure. MRIs are awful to go through. They take 40 minutes. You might be injected with some kinds of contrast material, but collecting language is not painful and it's not psychologically debilitating as going through an MRI. Language data can also be collected at home rather than at the clinic, which is great for patients because if you are an individual with cognitive decline, you tend to go to the hospital quite often. So you might want to avoid going to the hospital if you can. Again, psychologically, it's not great if you have to go to the hospital every 2 weeks. So if you can avoid going that often, it's always great. Finally, collecting language data is much faster than collecting brain imaging data. So for example, again, EEG is cheaper than MRI, but it takes ages for the participant to undergo, and it takes ages for the clinician to clean up after the EEG is done. So you've got a number of advantages that come with language analysis, which make language analysis particularly relevant and particularly promising as something that we can use to diagnose dementia. Any questions so far? Okay. How the future looks like. So what could we do in the future with this automatic language analysis? So what my team and I want to do is we want to live in a world where there is an app on your phone or something similar. You can open this app. You can say whatever the app asks you to say. So for example, the app might ask you to tell us what you had for breakfast or recall some memory that you want to share. This app is going to transcribe what you say, it's going to process it, and then based on the results that we get through this processing, it's going to suggest to you to get in touch with a doctor if the results warrant that kind of visit to the doctor. And this is going to be great for a number of reasons. For example, individuals with limited access to healthcare might be able to screen at home for early signs of Alzheimer's disease. So if you live far away from a memory clinic, like you live in the middle of Iceland, you're not very close to a hospital, you're not very close to a doctor, you could do this and still get some answers or still be prompted to go visit a doctor if your language features suggest that there might be something wrong with you. So this tool that we're developing is not just going to benefit the individual that can test for dementia and Alzheimer's disease at home, it's also going to be benefiting clinicians in a clinic. Because if you've got an additional, very cheap, very fast way of telling you whether you've got dementia, Alzheimer's disease or not, you can use that to confirm diagnoses that are made by a clinician at a hospital. And this is particularly relevant for diagnosing mild cognitive impairment. Mild cognitive impairment, sometimes it's hard to diagnose because if you are in the early stages of that stage, your cognitive symptoms might not be as evident. So sometimes you might not be diagnosed with mild cognitive impairment, even though you really should be diagnosed with that disease, with that stage of the disease. So if you've got an additional way of testing your cognitive health, and this way is very cheap and very fast, well, that's great. That's great for everybody. So if we want to use language to diagnose Alzheimer's disease and monitor the progression of Alzheimer's disease, we need to understand more in detail how language is affected in Alzheimer's disease. So we've seen some of the symptoms for healthy aging. We've seen the general symptoms that are associated with Alzheimer's disease. What we're going to be doing in the rest of this lecture is we're going to be focusing specifically on very distinct and very specific linguistic features. So we're going to be comparing phonetics, syntax, discourse features, semantic feature, lexical features, and see what happens to them if you've got Alzheimer's disease. So first of all, in general, there is, of course, a difference in how your language is affected if you've got Alzheimer's disease, depending on where you are on the scale of progression. So whether you are an MCI patient, so an individual with mild cognitive impairment, or an individual with severe dementia. In general, in the early stages, you experience difficulties with word retrieval. So you want to say something, you just cannot remember what the word for that thing is. And this is something, again, that we saw happening to healthy individuals as well. But crucially, if you've got Alzheimer's disease, this happens much more often. Because you have a hard time remembering the sound of the word that you need to say whatever it is that you want to say, you have a lot of pauses, a lot of hesitation. You say a lot. You generally speak much slower. You use all kinds of verbal fillers to fill the gap where the word that you need that you cannot recall should be. Also, you tend to stutter, you pause a lot again, or you just find it difficult to finish a sentence because you don't know the words that you need. And also, you're still in a position to form sentences, and your sentences still make sense, but you might be doing that more slowly than you used to do, again, because you have trouble remembering the words that you need. In the moderate stages of Alzheimer's disease, so mild dementia, moderate dementia, there is a progression for the worst of your language symptoms. You struggle to form simple sentences, and at this point, you also struggle to understand conversation. You struggle to understand what is being asked of you, and you struggle to provide answers that are coherent. We also notice that there is much more slurring, so the speech that you produce is much less clear. There is repetition of things that somebody might have said to you that you just repeat yourself, even though that makes no sense in that conversation. And there's also an increased use of incorrect words or incorrect phrases. Finally, in the severe stages, individuals may lose the ability to form coherent thoughts and speech. So they might say something which is completely unrelated to what is being asked or what is being discussed. Individuals, again, frequently repeat phrases they hear from mother, and they did so too during the moderate stages, but now it's even more common. And when you do have speech production, most of the time it doesn't make any sense. It's incoherent on the broader scale. So if you look at all the things that the individual says, and also if you look at the local scale, if you compare, for example, what sentence A leads to. So sentence A is going to be about baseball, and sentence B is going to be about soap. So there's no logical connection whatsoever. And then individuals may sing, babble, or say words that are related to the situation and conversation. Now, this is a very interesting video that I don't think we have any way of checking. I'll try again to play it and see if that does anything, but I suppose it's not, but we can try. Can you hear it? No? Okay. So maybe we can try later on, just going to YouTube, but let's move on for now. And then if we've got any time, we can try to go back to these videos, because this one especially is very, very sad, but also it gives you a very clear idea of the kind of issues that you've got with moderate dementia. So moving on. Zooming on the specific linguistic features. So right now we've just seen in general the kind of linguistic disfluencies that you have according to the stage of dementia, Alzheimer's disease dementia that you're in. Now we're going to be looking at acoustic features versus syntactic features versus lexical features. And that is because if we are going to develop this nice app that is going to be on your phone, we need to know what it is that tells us the most and what it is that can be the most effective in getting as much information as we can from our patient. Again, so we're going to be looking at acoustic features versus lexical features versus syntactic feature and discourse features. Starting with acoustic features. Acoustic features we'll see are some of the most promising features that you can look at when you're trying to diagnose Alzheimer's disease. Acoustic features refer to the acoustic feature of the speech that you produce. And with Alzheimer's disease, we see three main things that pertain to the acoustic quality of the language that you produce. First of all, individuals with Alzheimer's disease speak much more slowly. This is due to a number of reasons. One of the reasons is they just do not remember the words that they need. They're going to be producing many more pauses. So there's going to be a higher hesitation ratio for the very same reason. And these pauses are also going to be longer. We all produce pauses every once in a while, but the crucial differentiating factor here is that if you are older and Alzheimer's disease, your pauses are going to be longer because you struggle to form a sentence, you struggle to remember the words, you struggle to understand what you're supposed to be saying, you're confused in general, so there's lots of factors playing into the length of the pauses and the fact that you've got more pauses in general. The most characteristic features in the MCI phase, so the mild cognitive impairment phase, are longer hesitation and lower speech rate. Why do we specifically care about mild cognitive impairment? That is because mild cognitive impairment, if you recall, is the very first stage in the progression of Alzheimer's disease where you've got when you've got cognitive declines, there are cognitive deficits that are obvious, not just to you, but to everybody else. So in general, we're always very interested in trying to determine what kind of linguistic symptoms you can already tell, you can already see, obviously, in this stage, because it is a stage that is closer to the beginning of the progression of the Alzheimer's disease pathology. So if it's something that you can already pick up in this phase, it means that it's a very good feature that you could be looking at to potentially diagnose early stage dementia, which is the phase that we care about the most because it's when we can tell an individual that does not know that they have dementia, that they might have dementia. Syntactic features, so looking at the structure and the syntactic complexity of the sentences that are produced by individuals that have Alzheimer's disease. We're going to be looking at a specific study later on in the remaining half hour, and this is a Swedish study, and they noticed that individuals with mild cognitive impairment produce less main clauses, fewer main clauses that have a finite verb. So there is a higher proportion of verbs that are non-finite in the speech of individuals with MCI. Another study found out that there is a lower proportion of embedded adjunct clauses and adverbial adjuncts. Adverbial adjuncts are phrases like thoughtfully, I decided to visit my grandma, or regretfully, I hope that's a word, I could not attend the meeting. So it's an adverbial element that further specifies some of the qualities of the event that is described by the sentence. And then an embedded adjunct clause is an embedded clause like, while I was away, thieves broke into my place. And the explanation for why individuals with dementia have a lower proportion of these elements according to some of the authors that I've noticed this phenomenon, is that individuals have a harder time trying to create specific narratives, and they have a harder time trying to explain and describe events in detail. So because they have a hard time, for example, remembering things, they can provide fewer details when they're describing something. So all these adverbial elements that generally further qualify a specific action that is described in a sentence are the first ones to go. Another thing that pertains to the syntax of the speech of individuals with Alzheimer's disease is you have simpler syntax. And you can see this by looking at the number of embedded clauses. So if you are an individual with Alzheimer's disease, you tend to produce more coordination and less embedding. According to this very recent study by Chapin et al., the overall proportion of embedded adjunct clauses and adverbial adjuncts can be used to distinguish healthy controls from NCI patients. So again, we're always interested in those features that can differentiate healthy controls from individuals that are just starting to show the first cognitive deficits that are associated with Alzheimer's disease. And this feature, these two features actually, so the proportion of adjunct clauses and the proportion of adverbial adjuncts seem to be very promising in doing that. So again, in the context of developing our app, we might want to devise kind of language task that elicits these kinds of constructions, because we want to see how many the individual uses. And then we can compare that number to the number of these constructions that appear in the speech of a healthy individual, and we can make some conclusions, reach some conclusions. Concerning lexical features, so what kind of elements do we have in the speech of a person with Alzheimer's disease? So we have more adjectives, so we have more pronouns, so we have more whatever if compared to a healthy individual. One thing that has been mentioned by many different studies is that the pronoun to noun ratio is off. And that is because the number of pronouns is very much higher than it should be if compared to the number of nouns. So some authors claim that that is because individuals with Alzheimer's, first of all, cannot remember the words that they need. So if I want to say the mailman, I cannot remember the mailman, so I'm just going to say he came this morning. But also, the idea is that individuals with Alzheimer's have a harder time understanding what the person in front of them understands of the conversation. So I might say, for example, he came this morning, instead of saying the mailman came this morning, because I assume that the person in front of me knows what I'm talking about. So they know that I'm talking about the mailman, but in truth, they don't know that I'm talking about the mailman, but because I've got dementia, I think that that is a clear piece of information. Different studies, however, say different things. So for example, again, this very recent study by Chapin et al., according to them, yes, we have a higher number of pronominal elements, but it's not necessarily third person pronouns like he or she, it. It's generally second person pronouns that are more frequent in the speech of individuals with Alzheimer's. And that is because individuals with Alzheimer's tend to make generic statements, you did this, you did that, or they tend to just address their interlocutor a lot. Another thing that we notice is we have an increased number of generic reference. Again, think of, I want to say, please hand me the book. I don't say, please hand me the book, but I say, please hand me that thing, or please hand me that. Or overuse of like verbs. So what this lexical analysis paints as a picture is the picture of a person that has a lot of trouble to access specific words, and to bypass this problem, he or she tries to use more generic words, or tries to use pronominal elements instead. Discourse features. So this is actually related to lexical features a bit, but it's also its own category. And one thing to notice here when we're talking about discourse features is in the speech of individuals with Alzheimer's disease, we see a higher proportion of definite articles. So instead of getting sentences like a boy is stealing my purse, you'll get sentences like the boy is stealing my purse. According to many different authors, this suggests difficulties in establishing new discourse reference and in creating a coherent narrative. So once again, if I've got Alzheimer's disease, I might suspect, I might think that you know that I'm talking about a boy, and you might understand what I'm trying to say, but I sort of assume that you know that I'm talking about a specific boy, so I just use the boy instead, even though the boy that I'm talking about is a new reference, so it does not appear anywhere before in our conversation. It should be introduced with an indefinite article, but my Alzheimer's brain has a hard time trying to understand that. All right, so last part of this lecture, we're going to be looking at two specific studies that use automatic language analysis to detect Alzheimer's disease. Why is automatic language analysis such a cool thing? We spent 1 hour just looking at the different linguistic features that characterize the speech of individuals with Alzheimer's disease. And we see that there are many things that we can use to tell individuals with Alzheimer's apart from healthy individuals. So the potential to be using language to detect Alzheimer's disease is there. And with the technology that we have nowadays, that is also a concrete possibility, in the sense that up until 10 years ago, we were looking at language data and analyzing them manually. And of course, that is going to be taking ages. If you cannot have a computer do it for you, that's going to take a month. That doesn't make any sense. At that point, you could just go and have an EEG, which is still faster than, getting language data in that way. But now with the development of technology, we have automation. We can automatize these kinds of language analysis. So we can use natural language processing toolkits that can tell us that this word is an adjective and that word is a verb automatically. And they can process a lot of data, so we can get lots of information very fast on how many adjectives this specific transcription contains. So that is great. And we also have machine learning algorithms that can quickly classify language data into classes and do so very fast and by looking at language data that these algorithms never saw before. So what does that mean in practice for us? It means that through automation, not only can we process more data, not only can we process data much faster than we could do manually, but we may also be able to discover patterns that are not evident to us as humans doing manual transcription, manual analysis, but they might be evident to a machine learning algorithm. So the potential to use language to diagnose dementia is suddenly much, much more relevant and much, much more promising. We're going to be looking at two studies, and the first study that I want to be talking about is this article called Speech Analysis by Natural Language Processing Techniques, a possible tool for very early detection of cognitive decline. So just by looking at the title, you see that one of the main concerns as clinical linguists and as individuals working with natural language processing is, how can we use natural language processing to for early detection of Alzheimer's disease? This is a relatively recent article. It was published in 2018. There are many more articles as the years progress. I saw literature review that was checking articles written in 2019, and they were saying we found 30 relevant articles. And then I saw a literature review that was checking articles written on natural language processing and dementia in the year 2021, and suddenly there were more than 100. So this is definitely a field that is very recent and it's blowing up. You got more publication on this about a year, and you got more publications on different languages. So not just English, but Icelandic, Italian, French, Spanish, and other languages. Okay, so Beltrami et al. So this is an Italian study dated 2018, and what they were trying to do was they wanted to determine if NLP, first of all, can be used to successfully discriminate between healthy individuals and individuals with Alzheimer's disease. Not only that, they wanted to look specifically at which linguistic features are the most revealing of an AD pathology. So which linguistic features should we be looking at to determine if somebody has Alzheimer's disease or if they're just getting old. So this is an experimental study. So they collected data from participants. These participants were quite a few. So they had almost 100 participants, 96 participants, and the range, age range was 50 to 75, which is pretty young, actually. So we're also testing participants, but we test participants that are older than 60 and younger than 80. They had different research groups. So they had 48 healthy controls, so individuals that are just healthy, they have no known pathology, and then 48 individuals that had dementia, Alzheimer's disease dementia at different stages. So they tested 16 individuals with MCI, amnestic MCI, 16 individuals with multiple domain MCI, and 16 individuals with early dementia. Amnestic MCI is a term used to describe individuals that have MCI, so mild cognitive impairment, but the cognitive deficits are only visible at the level of memory. So you can only notice that these individuals have a hard time remembering things. Multiple domain MCI is the stage after this. So it is when you've got MCI, so mild cognitive impairment, and it's not just the memory that is affected anymore. You've got issues also making decisions or understanding where you are. So you get lost, all those kinds of additional cognitive deficits. Beltrami et al. Wanted to record spontaneous speech, so they asked participants to answer the following questions. Could you please describe this picture? Could you please describe a typical working day? Could you please describe the last dream you remember? So the very first picture is a very, very, very common way of getting information out of patients with Alzheimer's disease, but also aphasia in general. So you might have seen this specific picture already. Has anyone seen this? No? Okay. If you study aphasia, you might see this because it's a very commonly used technique to elicit speech in populations that have language disfluency. So this picture is called a cookie theft picture. And what you do when you're trying to elicit linguistic data from an individual is you show them this picture and you ask them to describe what it is that they see. What are the advantages of doing this kind of task? Well, the picture is always the same. So individuals, if you test 40 different individuals, these 40 different individuals are probably going to say very similar things, which makes it really easy for you to compare things like the syntax used by this individual is much more complex than this other individual. So it makes, using a task like this makes it very easy to compare what is going on and what is the difference between different participants. The disadvantage of this is that you really don't get a lot of data using this technique. So for example, we are also asking our participants to describe a picture, not this one, but a different picture. And we noticed that generally you only get 2 minutes of data, linguistic data, and that is because you can only say so much. So you can say there's a boy trying to steal the cookies, there's a woman washing the dishes. Especially if you're not a very observant person, you might not have lots to say. So Beltrami et al. Also included these additional questions. The second one is particularly interesting. Could you please describe a typical working day? Because this is clearly added to the experimental protocol to activate episodic memory, because if you need to describe a typical working day, you need to remember what your typical working day looks like, which engages episodic memory, which we know to be impaired in older individuals, but especially in individuals with Alzheimer's disease. So this is a very potentially revealing kind of linguistic task. So what they looked at are different kinds of parameters. So they looked at lexical, syntactic, and semantic parameters. And to do that, they had the conversation that they recorded manually transcribed. And once they were transcribed, they were POS tagged. So they used toolkits that could tell, okay, this word in this sentence is an adjective, or this word in this sentence is an article. And they were also parsed, meaning that they could get automatically the syntactic structure of all the sentences that were present in the transcription. So they could tell the sentence as a subject and an object, depending on the kind of parsing system, but you got my picture. Or they could tell this sentence has an embedded clause and a main clause. This, as far as the lexical, syntactic, and semantic parameters were concerned. They also looked at acoustic parameters, and to do that, they use a specific software called voice activity detector that segments recording into parts where somebody's saying something and parts where nobody's saying something. And that is very relevant because we saw that individuals with Alzheimer's disease produce a lot of pauses. So if you want to use acoustic speech features of speech to see if somebody has Alzheimer's disease, you need to have a way of identifying how many pauses there are and the length of the pauses. So they computed a number of lexical, acoustic, and syntactic values using voice activity detector, so the software, and also the tagged and parsed transcriptions. And then they tried to see which features were statistically significant in distinguishing between different research groups. So which of these features, out of all the things that they looked at, could tell us whether somebody is a healthy control or an individual with mild cognitive impairment. They found, when it comes to acoustic features, that features that were statistically significant were the duration of pauses, so how long the total amount of silence was essentially in a conversation, the duration of speech in general, and transformed phonation rate, which is a measure that correlates pauses versus all the things that are said in a specific amount of time. The conclusion that Beltrami and et al. Made is that in general, most of the acoustic features that they looked at were quite significant in determining if somebody was a healthy control or not, which makes acoustic feature quite promising in detecting early Alzheimer's disease. When it comes to lexical features, they noticed that the features that were statistically significant were the ratio of closed class words versus open class words. So essentially looking at how many nouns, verb, adjectives, and adverbs there are in a conversation and comparing those numbers to the numbers of elements such as pronouns, determiners, and the like, and seeing which one is higher. So basically they noticed that if you've got Alzheimer's disease, even in the early stages, you produce more closed class words. So you produce fewer nouns and you produce more closed class words like pronominal elements, which is something that we saw already. The ratio of pronouns, again, was something that distinguished different research groups, and also the mean number of words in utterances. Meaning, if you've got Alzheimer's disease, you tend to produce shorter sentences, so sentences that have fewer words and that are syntactically less complex, just because you have less words in the sentence. Statistically significant syntactic features, you've got utterance length. So again, sentences were shorter, and maximum depth of structures, meaning that on average, the sentences produced by an individual with Alzheimer's disease had fewer embeddings. So they had fewer embedded clauses in general. One thing that is important to comment, to notice, is that you had statistically significant features that could distinguish between different research groups, but whether they were statistically significant or not depended on a specific task that was studied. So if you remember, Beltrami et al., they had 3 different language tasks, 3 different questions that they were asking. The first one was, please describe this picture. The second one was, please describe your typical working day. And the third was, please describe your dream. So if we look, for example, at, let's see, content density, which is the ratio of closed class words versus open class words, we see that this is only a statistically significant linguistic feature in the figure description task. It's not statistically significant in the working day description task. And this is very relevant, again, in the context of developing an app on your phone that can tell you if you've got dementia or not, because you need to pay attention to what kind of question you ask participants on the app. Because if you ask the wrong question, so for example, if you ask, describe your working day, you might not be able to use content density as a biomarker to detect Alzheimer's disease. The same goes for syntactic features. So for example, syntactic complexities was not a statistically significant feature in the picture description task, but was a statistically significant feature for other kinds of language tasks. All right, so automated syntactic analysis of language abilities in persons with mild and subjective cognitive impairment. I'm going to skim through this very quickly because I'm running out of time. This is the second study that I wanted to go through, and it's a study processing Swedish conversation. And it's also dated 2018. So what they were doing in this study is they wanted to see if syntactic features, so not just any kind of linguistic feature, but syntactic features specifically, could discriminate between individuals with MCI, so mild cognitive impairment, and individuals with subjective cognitive impairment. What is subjective cognitive impairment? It is a condition whereby you go to the doctor and you say, doctor, I've noticed recently that my memory has been getting much, much worse. So the doctor has you take some tests, but the tests don't really tell anything. So they essentially say you're healthy. So it is subjective because you yourself notice that there is something potentially wrong with you, especially in terms of your memory capacity. But if there is something wrong with you, it's not something that is picked up by cognitive tests yet. And this condition is very interesting for us, people that study Alzheimer's disease, because 50% of people that say they've got subjective cognitive impairment will turn to be patients with mild cognitive impairment in less than 5 years. So Force et al. Had 90 participants, 36 healthy individuals, 31 participants with MCI, and 23 participants with SCI. They elicited conversations, so linguistic data using the cookie theft picture. They transcribed the responses given by individuals, and then they parsed these conversations. The main conclusion is that there was no statistically significant difference for any of the features that they looked at. So they looked at a variety of syntactic features, but none of them could really statistically significantly tell if somebody was a healthy individual or a person with mild cognitive impairment or SCI. But they did notice that some features approached statistical significance. So for example, an increase in the number of false starts and an increase in the proportion of clauses, main clauses that contained a verb that was not finite. Conclusions. Episodic memory and word retrieval are affected in both healthy aging and pathological aging. This is something that we need to consider if we want to develop mechanisms that can determine if somebody has dementia or not based on language analysis, because we need to understand what is normal and what is not normal. And we need to understand that as you age, there's going to be differences in the way that you say things and recall things. So some of those are normal, some of those are not. And very often, so for example, when it comes to word retrieval difficulties, it's really just about the number of issues that you've got per sentence or per conversation. Since language is affected by Alzheimer's disease, we can use linguistic features as biomarkers of Alzheimer's disease. We can use linguistic features to potentially tell somebody if they've got Alzheimer's disease, but we can also use linguistic features to better monitor the progression of the disease, which makes us linguists people that are in a very privileged position to be doing something about dementia, and so to be helping these individuals getting the answers that they deserve, because that is exactly what we do. So we look at language and we try to draw conclusions out of that. We've seen that acoustic features of speech seem particularly promising biomarkers. So again, in reference to the first study that we looked at, the Italian study, recall that they were saying most of the acoustic features were statistically significant. Presumably, multimodal approaches are more effective. So one should not just look at acoustic features, even though they're quite nice to be looked at, because you don't have to worry about the specific language that you're thinking about. So Icelandic and English, you can just look at the number of pauses, the duration of pauses. So it's a very language agnostic, in a sense, kind of methodology. But if you do look at more linguistic parameters, generally speaking, we expect that the accuracy with which you can determine if somebody has dementia or not is going to be better. And the final consideration that I was making is that the modality with which you collect the speech, so the kind of question that you ask individuals to get linguistic data out of them, is very relevant in that it might influence whether you can use a specific linguistic feature like syntactic complexity to determine if somebody has dementia or not. So if you're asking somebody to describe a picture, you might not need to focus on syntactic complexity, but you might want to focus on the number of pronominal elements, for example. And that is it. Thank you very much. Let me stop the share, and then you have quickly time for questions. Sorry, I ran a bit over with the time. So if anyone has questions, please go ahead. Now is your time.
Hello, I just want to thank you for your presentation, because I am psychologist, so for me this is a really interesting approach, because I think that the language performation or something from the older people, or the patients with some diagnosis, or with the patients that we are not sure about their diagnosis, it is really good information to us, or really interesting, or something. Yeah. And I just want to ask you if this AI analysis processes or application that they are available like for free use, or maybe, or it's just some own some own of the project people or someone. Thank you.
Right. So thank you. Thanks, first of all, for the nice comments. And thank you. I also think this is very useful, and it's also very interesting as a field of research. To answer your second question, there is nothing that has been approved yet. There are multiple people in multiple universities trying to create what we're also doing here in Iceland, but it's mostly at the development stage. There are also a few companies that are doing this. So there is a company called Novoik, which is based in the UK, if I'm not mistaken. And they're trying to develop an app that you have on your phone. And I think they're asking you to listen to a story and try to recall as many details of the story as you can, but it's not been approved yet. So they're developing it. They probably have something already that is working, but it's not being approved for use in clinical settings. Okay, well, if you have any questions or comments, or just want to know more about what we're doing, you can ask Ludmila for my email address, and you're very welcome to email me and shoot me a line about anything that you want to know or know more about. And yeah, thank you very much for joining. I hope this was interesting, and yeah, see you soon. Have a nice rest of the day.